Good morning, ma'am. I am Sharapova Elman, and today I will be discussing about the physiological and pathological jaundice in newborns. So, here is my objectives. By the end of this self-directed learning, I will be able to first understand the definition, causes, and risk factors of physiological and pathological jaundice in newborns. Second, differentiate physiological jaundice from pathological jaundice in newborns. Third, create a systematic approach for assessing and managing jaundice in newborns. And lastly, critically evaluate various treatment options and their effectiveness in managing neonatal jaundice. So, let me define what is jaundice. So, jaundice is the yellow discoloration of the skin, sclera, and mucous membranes due to elevated levels of bilirubin in the blood or the hyperbilirubinemia. So, there are two types of jaundice, the physiological jaundice and the pathological jaundice. So, physiological jaundice. Physiological jaundice is a normal process in most newborns caused by immature liver function and increased bilirubin production. So, the causes are or includes immature liver enzymes. So, the newborn's liver isn't fully developed, so it processes bilirubin more slowly. The next is shorter lifespan of fetal red blood cells. These RBCs break down faster, producing more bilirubin. And lastly, increased enterohepatic circulation. So more bilirubin is reabsorbed from the intestines instead of being excreted. So for the risk factors, this includes prematurity, delayed feeding, exclusive breastfeeding with poor intake, East Asian ethnicity, or the family history. Next is the pathological jaundice. So, pathological jaundice is the abnormal jaundice due to an underlying condition, appearing earlier or lasting longer than physiological jaundice. So, the causes includes hemolytic disease or ABO or RH incompatibility. ABO or RH incompatibility causes rapid red blood cell destruction. So, the G6PD deficiency, a genetic disorder that makes red blood cells break easily under stress. And the next is the infection or the sepsis or TERCH. So infections can impair liver function and increase bilirubin. So TORCH stands for T. Toxoplasmosis, O for other infections like syphilis, varicella zoster, parvovirus B19, then R for rubella, then C for cytomegalovirus or CMV, and then H for herpes simplex virus or the HSV. So these infections can lead to jaundice, hearing loss, developmental delays, or congenital abnormalities in affected newborns. The next is the cephalohematoma or the birth trauma. So bleeding under the scalp increases bilirubin from blood breakdown. Then lastly, the genetic or metabolic disorders, conditions that affect how the liver processes or removes bilirubin. Then for the risk factors, jaundice within the first 24 hours. Then the bilirubin is rising more than 5 milligrams per deciliter a day, and then total bilirubin is more than 17 milligrams per deciliter. Then signs of illness such as fever, poor feeding, and then lethargy, or the unusual weakness of the baby. So I have here a scenario illustrating physiological jaundice. So the scenario is baby Liam born at 38 weeks via vaginal delivery appears yellow on day 2. He is exclusively breastfed, feeding every 3 to 4 hours. His bilirubin level is 13.5 milligrams per deciliter on day 3 and he has no fever or signs of illness. So interpretation. This is likely physiological jaundice, managed with increased breastfeeding and monitoring, and then phototherapy only if bilirubin crosses treatment threshold for age. And now, I will proceed to the differences between physiological jaundice and pathological jaundice. So, I have here the criteria. So, for the onset of physiological jaundice, it is about 24 hours of birth, and for the pathological jaundice, within first 24 hours of prolonged beyond 2 weeks. And for the cause, of physiological jaundice, it is the immature liver function. For the pathological, the underlying disease, for example, hemolysis or infection. And for the bilirubin level, for the physiological jaundice is mild to moderate, which is less than 12 to 15 milligrams per deciliter. And for the pathological, it is often more than 17 milligrams per deciliter or rising rapidly. And for the symptoms, for physiological, no other clinical signs, and for pathological, may show fever, lethargy, or the poor feeling. And then for the duration, for physiological resolves by day 7 to 10 in term infants, and for pathological lasts longer and may require intervention. For the treatment for physiological, often none or phototherapy. And then for pathological, may require intensive treatment such as exchange transfusion. And for the kernicterus risk, for the physiological is low, while the pathological is high if untreated. So, here are the systematic approach for assessing and managing jaundice in newborns. So for the assessment plan, first is you have to take a history taking. So for the birth history, feeding pattern, and family history. The second is the physical exam. You have to check the skin, sclera, mucous membranes, the bilicheck zones, or the cephalocodial progression. Third is the diagnostic tools. This is the transcutaneous bilirubin or the TCB or total serum bilirubin or the TSB. The use of butane nomogram for risk assessment. And lastly, you have to identify the risk factors. So for the prematurity, hemolysis, sepsis, and etc. For the management plan, for the mild or physiological, so monitor bilirubin levels, encourage frequent breastfeeding, phototherapy if approaching treatment threshold, and for the moderate to severe or the pathological. And now I will be evaluating the various treatment options and their effectiveness in managing neonatal jaundice. So first treatment option is the phototherapy. So its effectiveness is very effective for mild to moderate hyperbilirubinemia and then breaks down bilirubin into water-soluble form. And next is the exchange transfusion. This is highly effective for severe or dangerous levels, rapidly reduces bilirubin, riskier reserved for emergency cases. The next is the feeding support. It helps increase bilirubin excretion via stool or urine, and it's effective in mild cases. Fourth is the IV fluids. So IV fluids is useful when dehydration is a factor. It supports kidney function and bilirubin excretion. Then lastly is the treating underlying causes. Critical and pathological jaundice such as antibiotics for sepsis and then stop hemolysis. So that is all for physiological and pathological jaundice in newborns. So thank you for listening, ma'am. God bless.